want you to just think about something you've probably already done, I don't know, hundreds of times today.
Right.
And you did it without giving it a single conscious thought. Like maybe you just smiled at a text message.
Right.
Or maybe you furrowed your brow trying to remember where you left your keys. Or honestly, maybe you just blinked.
Yeah, completely effortless.
Exactly. Effortless. But underneath the skin, that seemingly spontaneous movement relies on a mechanical and neurological system that is so complex, it basically makes modern robotics look, primitive.
Oh, absolutely.
So today, we are doing a deep dive into some incredible surgical data regarding facial reanimation. We're drawing heavily from Chapter 95 of Scott Head and Neck Plastic Surgery.
It's a fantastic source.
It really is. And our mission today is to explore the hidden machinery of the human face, figure out the devastating, cascading structural failure that happens when that machinery suddenly loses power, and uncover the mind-bending surgical engineering doctors use to literally bring a frozen face back to life.
So let's unpack this.
Let's do it. Because the human face isn't just a static canvas.
No, not at all. I mean, it is a highly specialized, highly integrated biological machine. We tend to think of facial paralysis in purely cosmetic terms, right? Like a drooping smile, where we throw around labels like Bell's palsy.
Right, which people hear all the time.
They do, but by the way, Bell's palsy is strictly a diagnosis of exclusion.
Wait, meaning what exactly?
Meaning a doctor will only use that term after they have aggressively ruled out literally every other possible structural cause, things like tumors or severe trauma.
Okay, got it.
But focusing on just the cosmetic aspect completely misses the severity of what's actually happening. You have 17 paired muscles of facial expression, plus there's a vital circular muscle around the mouth called the orbicularis oris.
17. That's a lot of wiring.
Yeah, and unlike a bicep, where it just pulls bone to bone to move a heavy joint, these facial muscles often connect soft tissue to soft tissue, or they anchor directly into the underside of your skin. So they require incredibly precise, nuanced electrical signals just to maintain their resting tension.
So when the main power cable, the facial nerve, basically gets cut or damaged, you aren't just losing an expression.
No.
You're losing the fundamental mechanical tension of those 17 paired muscles. It's a complete mechanical failure.
Exactly. The entire system goes into structural collapse. I mean, take the mouth, for instance. Without the constant tension of the lip and cheek muscles, the patient loses what is clinically called oral incompetence.
Which means they can't seal their lips.
Literally, yes, you cannot maintain a pressurized seal. Drinking a glass of water becomes impossible because the liquid just spills outside your mouth.
That sounds incredibly frustrating.
It is, and speaking clearly becomes incredibly difficult, particularly with words containing plosive sounds like P or B.
Because you can't build up the air pressure.
Right, you can no longer build up air pressure behind your lips to sort of pop the sound out, and even eating becomes physically dangerous.
Dangerous. How so?
Well, the muscle that normally keeps the inside of your cheek taut, out of the way of your teeth, it goes completely limp. So patients end up constantly and painfully biting the inside of their own mouth while just trying to chew their food.
Oh man. So it's like a highly pressurized, perfectly sealed plumbing and ventilation system, and when one valve fails, the whole house floods.
That is a perfect analogy.
But the structural failure moves up the face too, right? As the source mentions, the airways physically cave in.
Yeah, nasal valve collapse. It is a terrifying functional reality. The tiny muscles that normally flare your nostrils outward and keep the nasal passages rigid, they lose all their tone.
So what happens when they try to breathe?
Every single time the patient tries to inhale through their nose, the negative air pressure acts like a vacuum. It literally sucks the lymph nostril completely shut against the center septum. It physically suffocates the airway on that side of the face.
That is wild. But I think the part of this breakdown that feels almost impossibly cruel is what happens to the eye.
The eye is a massive issue.
Yeah, because the data shows that patients with a paralyzed face often suffer from something called epiphora, right?
Right.
Which is a constantly watering eye, tears just pouring down their cheek.
Yeah.
But at the exact same time, the text says they are in imminent danger of going completely blind from severe eye dryness.
It's a total paradox, yeah.
How does an eye that is literally overflowing with tears end up dying of thirst?
Well, it comes down to understanding that blinking is not just a windshield wiper, it is an active mechanical pump.
Okay.
You have a circular muscle around the eye called the orbicularis oculi. When it contracts to close the eyelid, it physically squeezes the tear glands, pumps a fresh layer of moisture across the clear cornea, and then pushes the used tears down into the tiny drainage ducts near your nose.
So it's an active pumping mechanism.
Exactly. When that muscle loses power, two catastrophic things happen. First, you just can't close the eye at all. It's permanently exposed to the air.
Oh, wow.
And second, the lower eyelid loses its tension and sags downward and outward, physically pulling away from the eyeball.
And that's what the source calls paralytic atropion.
Yes, paralytic atropion.
So the eye keeps producing tears, but the pump is broken, and the drain is essentially disconnected.
Right, the tears just pool up in that sagging lower lid like a broken rain gutter, and they spill over onto the cheek.
While the actual surface of the eye gets nothing.
Exactly. The clear surface of the eye, the cornea, is completely exposed to the open air without any moisture being pumped across it. It dries out rapidly, leading to severe ulceration.
And blindness.
Yes. If a surgeon does not intervene, the patient will go permanently blind.
See, this is where I have to pause and look at the broader picture here. Because we're talking about airway collapse, the inability to eat, imminent blindness. With all these massive, critical physical emergencies happening all at once, do doctors sometimes overlook the psychological toll? Like the human being trapped behind a paralyzed face?
That's a great question. And look, surgeons have to focus on the biological machinery first because the biology forces their hand.
Right, the timer is ticking.
Exactly. If a surgeon pauses to address the patient's psychological state before fixing the anatomy, that patient will permanently lose their vision in a matter of weeks. The timeline for an exposed cornea is totally unforgiving.
That makes sense.
But having said that, once those immediate structural threats are managed, the medical community is acutely aware of the profound psychosocial trauma at play here.
Because you lose what's called mimetic expression. You basically lose the ability to communicate before you ever open your mouth.
We rely entirely on microexpressions. A slight smile to show you're listening, a raised eyebrow of curiosity, a look of empathy. When that vanishes, social interaction becomes an absolute minefield.
People misinterpret the blank face.
All the time. People subconsciously misinterpret a paralyzed, immobile face as anger or apathy or even a lack of intelligence. The patient's self-confidence is absolutely shattered.
Which naturally leads to isolation.
Intense isolation, and very frequently severe depression. So restoring that emotional connection is the ultimate goal. But to get there, surgeons first have to figure out exactly where the electrical system broke down.
Right, and finding the break means tracing the facial nerve all the way from the brain out to the skin.
Yeah.
It's literally like mapping a power grid failure.
It really is. Surgeons categorize the etiology, or the causes of the damage, based on its anatomical geography. They divide the nerve's journey into 3 distinct zones.
Okay, let's go through those.
First is intracranial, meaning inside the brain or the brainstem. The breakdown here is usually caused by central nervous system issues, vascular abnormalities, or deep-seated tumors.
Okay, so that's zone 1.
Then the nerve exits the brain and enters the intertemporal zone.
Meaning it travels into the temporal bone of the skull, like right behind the ear.
Right. It enters a very tight, twisting, bony tunnel, and this is a massive bottleneck. If a patient gets a severe infection there, or if trauma causes a fracture at the base of the skull, the nerve swells.
But it's trapped in bone.
Exactly. There is zero room for expansion. The nerve essentially crushes itself against the unyielding tunnel walls.
Ouch.
Yeah. And finally, it exits the skull into the extratemporal zone, branching out across the face and running directly through the parotid gland in your cheek.
Which is where things like deep lacerations happen.
Right. Parotid malignancies, lacerations, or severe face trauma sever the nerve pathways right there.
What blows my mind is how doctors pinpoint the exact location of the damage without instantly cutting the patient open. They look for these incredibly subtle clinical clues. Like the source mentions the patient might come in with a drooping face, but they also complain that normal sounds are painfully loud hyperacusis and they've completely lost their sense of taste.
It's essentially diagnostic deduction. Think of the facial nerve like a main fiber optic trunk line. As it travels from the brain toward the face, it splices off tiny side cables to serve different functions.
Okay.
One of those side cables goes to the tongue to carry taste signals. Another cable goes to a microscopic muscle inside the ear called the stapedius.
What does the stapedius do?
Its entire job is to contract and dampen the mechanical vibration of loud noises to protect your hearing.
So if the patient has a paralyzed cheek, but they've also lost their sense of taste, and every sound is deafening.
The surgeon knows instantly that the break in the fiber optic cable has to be high up in that bony canal. It has to be before those specific side branches split off.
That is brilliant.
Okay.
So once they locate the injury, how do they measure the severity?
Clinically, Essentially, they use visual grading scales like the House-Brackman or Sunnybrook systems. They're looking for microscopic asymmetries, like a resting eyelid droop of just 1 or 2 millimeters to gauge the exact voltage running through the nerve.
But they can actually see the current, right?
Not with the naked eye. To actually see inside the nerve, they rely on electroneurography or ENOG.
Which is sending an electrical pulse directly into the nerve to see how much of the muscle actually fires in response.
Exactly. They are measuring the exact percentage of nerve degeneration. If the ENOG test shows that more than 90% of the nerve fibers are dead, the chances of spontaneous natural recovery just drop off the cliff. Wow. And there are varying levels of nerve injury. You have neuropraxia, which is essentially a temporary conduction block, like a bruise where an internal wiring is still intact. But then you have the absolute worst case scenario, which is neuromesis.
Meaning the electrical cord is completely severed.
Fully cut, yes.
So knowing the cord is fully severed introduces a terrifying biological timer. Because if the nerve is cut, how fast does a regenerating nerve actually travel and how long do we have to fix it?
The reality of the timeline is incredibly heavy. When a surgeon reconnects a severed nerve or grafts a new piece of nerve in, that nerve does not turn back on instantly like flipping a switch.
It has to grow.
Nerves physically grow. They extend their microscopic fibers at a painstaking rate of about 1 to 4 millimeters per day.
1 to 4 millimeters a day. That is agonizingly slow.
It is. And patients are racing against a brutal biological point of no return, 18 months.
What exactly happens in 18 months?
Irretrievable atrophy. Without the constant baseline electrical buzz from the nerve, the facial muscle fibers literally starve. They degrade, die off, and are entirely replaced by internal scar tissue and fat.
So after a year and a half.
After a year and a half of denervation, even if you perfectly reattach the main nerve cable, there's no muscle left to receive the signal. The motor is gone forever.
Wow.
If we connect this to the bigger picture, this biological clock dictates the entire surgical strategy. If a patient suffers a sharp facial laceration, surgeons ideally want to get in there within 72 hours to sew the severed nerve ends directly back together.
Immediate repair.
Right. But if they are dealing with a delayed repair, a complex case where they have to harvest a nerve from the leg and tunnel it across the face, they have to calculate the distance. If it takes the nerve fibers 6 to 9 months just to grow across the cheek, the surgery must be performed well before that 18-month window closes.
Time is completely of the essence. And because that window is so incredibly tight, we come back to what you mentioned earlier about priorities. You cannot wait 9 months for a nerve to grow while the eye is actively drying out.
You absolutely cannot.
The structural emergency takes precedence. Acquired lagophthalmos, that inability to close the eye has to be fixed immediately. But how do you mechanically force a biological flap of skin to close against gravity, especially when the muscle designed to pull it shut is completely paralyzed?
You actually enlist gravity to do the heavy lifting for you. Surgeons will surgically implant solid gold weights directly into the patient's upper eyelid.
Here's where it gets really interesting. Solid gold weights. It sounds like something out of an ancient burial, right?
I know, it sounds bizarre,
Yeah.
but it is one of the most elegant, highly effective structural solutions in modern surgery.
Why gold specifically?
They use highly purified gold because it is incredibly dense, meaning a very heavy weight takes up almost no physical space, and it is highly biocompatible, so the patient's immune system rarely attacks it.
So they just weigh the eyelid down.
The surgeon selects a specifically calibrated weight, usually between 0.6 and 1.0 grams. They make a microscopic incision and anchor this tiny gold plate directly to the tarsal plate, which is a thick, rigid band of connective tissue inside your upper eyelid.
It's basically like installing a tiny, perfectly calibrated lead sinker on the bottom of a window blind.
Yes, and the mechanics of it are brilliant because the muscle that lifts the eyelid, the levator muscle, is powered by a completely different cranial nerve.
Oh, so it's not paralyzed.
It is completely unaffected by the facial paralysis. It is strong enough to easily lift the eyelid, gold weight and all, so the patient can keep their eye open normally during the day.
Okay, but when they want to close it?
The moment the patient relaxes that levator muscle to blink or closes their eyes to sleep, gravity catches the gold weight and forcefully drops the window blind, sealing the eye shut.
That is just amazing. Using gravity to override a biological electrical failure.
Pure structural engineering. And the clinical data backs it up beautifully. It boasts around a 78% closure rate, and it resolves that dangerous corneal inflammation in virtually 100% of cases. It saves the eye.
Wow, okay, so that takes care of the upper eyelid. But what about the lower eyelid dropping? Gravity won't help us there, right? Gravity's pulling everything down.
Yeah, gravity is the sworn enemy of the paralyzed lower face. Surgeons have to mechanically hoist the lower lid back into position.
How do they do that?
They take an architectural approach. They might use a McLaughlin lateral tarsorrhaphy, or they harvest a piece of rigid cartilage from the patient's ear, the conjugal cartilage, and surgically slide it into the lower eyelid. It acts like a stiff internal strut, permanently propping the eyelid up against the eyeball.
And they use a similar structural approach to fix the airway, right? To stop the nose from caving in on itself.
They do. To prevent that vacuum collapse of the nasal valve, they will use tendon slings. They anchor one end to the paralyzed nostril and drill the other end directly into the maxillary periosteum, the tough membrane covering the upper jawbone.
To hold it open.
They literally winch the nasal base open and tie it off, permanently bracing the airway open so the patient can breathe.
So you are winching airways open with tendons, bracing eyelids with ear cartilage, dropping window blinds with gold weights. It's incredible. But once these critical structural emergencies are handled, once the eye is saved from blindness and the patient can breathe, the focus finally shifts to the ultimate goal, giving the patient back their smile.
And restoring dynamic movement to a paralyzed face is arguably one of the most complex challenges in plastic surgery.
Right, because there are static solutions versus dynamic solutions.
Exactly. Static solutions are much simpler. A surgeon might take a strong strip of tissue like the fascia lata from the patient's thigh, or plantaris grafts, and anchor it from the corner of the drooping mouth up to the cheekbone.
Just acting like an internal suspension cable.
Yes. It acts strictly to achieve resting symmetry. The face looks balanced when the person isn't trying to move. And surgeons actually intentionally overcorrect during this procedure, pulling the corner of the mouth up a bit too high.
Why overcorrect?
Because they understand the biological reality that human tissue inevitably stretches. Over the months following surgery, that internal sling will relax and settle into a natural position.
Got it. But it is static. It doesn't move.
Right. To get a face that actually smiles, you need a dynamic solution. You need a brand new motor.
Because the original muscle underwent irretrievable atrophy. The 18-month clock ran out, so you have to bring in a replacement.
Historically, surgeons tried regional muscle transfers. They would take a muscle already located in the head, like the masseter muscle, which is a powerful jaw muscle used for chewing.
Which seems like a logical shortcut. The muscle is right there.
It is a logical anatomical shortcut, but functionally it is deeply flawed. First, chewing muscles are incredibly bulky. Swinging a thick jaw muscle across the delicate tissues of the cheek creates an unnatural, highly visible bulge.
Well, that makes sense.
And second, because it is wired specifically for chewing, every time the patient sits down to eat a meal, their mouth twitches and pulls wildly with every single bite.
Yikes, so what do they do now?
The modern gold standard abandons that approach entirely in favor of microsurgical free-functioning muscle transfer.
Okay, break down the mechanics of this. How do you free transfer a living muscle?
It is an absolute masterclass in surgical engineering. The surgeon goes to another part of the patient's body, most commonly the inner thigh, to harvest a small portion of the gracilis muscle, or sometimes the pectoralis minor from the chest.
Okay.
But they don't just cut the muscle tissue out. They carefully extract the muscle along with its dedicated blood supply, the artery and draining vein, and its specific motor nerve.
The whole package.
The entire biological package. They bring that up to the face, transplant the new muscle into the cheek, and meticulously angle it to precisely recreate the mechanical pull of a natural smile.
But wait, a muscle cannot survive without blood. It is totally unhooked from the circulatory system.
This is where the surgical microscope comes in. Using sutures thinner than a human hair, the surgeon splices the tiny artery and vein of the transplanted muscle directly into the living blood vessels of the face. They instantly restore blood flow to keep the new motor alive.
That's amazing. But the motor still needs an electrical signal to fire. How do they plug the nerve in?
There are two main pathways for wiring this new muscle. The traditional route is the two-stage approach, which relies on the healthy side of the patient's face to power the paralyzed side.
So stage 1.
In stage 1, the surgeon takes a long sensory nerve from the leg, usually the sural nerve. They plug one end of it into a working facial nerve branch on the healthy side of the face, and they physically tunnel the rest of the cable under the skin across the upper lip, leaving the dead end sitting in the paralyzed cheek.
And then they just close the patient up and wait.
They wait for 6 to 9 months. They have to let those microscopic nerve fibers grow across the face, millimeter by agonizing millimeter.
Right, the 1 to 4 millimeters a day.
Exactly. Once the nerve fibers finally reach the paralyzed side, the surgeon performs stage 2. They bring the gracilis muscle up from the thigh and plug its motor nerve into that newly grown cross-facial cable.
So the optical signal actually originates on the healthy side.
Yes. When the patient's brain sends a spontaneous emotional command to smile, the signal fires the healthy cheek, travels across the lip tunnel, and fires the transplanted thigh muscle in the paralyzed cheek at the exact same fraction of a second.
Giving them a completely spontaneous smile.
It creates a beautifully synchronized, emotionally driven smile.
It's brilliant. But I mean, it requires 2 major surgeries and almost a year of waiting. I know there's a faster method, the one-stage approach, but the mechanics of it sound almost impossible.
The one-stage approach is significantly faster, but it requires a radically different power source. Instead of waiting for a nerve to grow all the way across the face, the surgeon transplants the thigh muscle into the cheek and immediately wires its motor nerve directly into a branch of the 5th cranial nerve, specifically the masseteric nerve.
The nerve that controls the jaw.
The nerve dedicated entirely to the mechanical act of chewing. It produces an incredibly strong, robust electrical signal, so the resulting smile is very powerful and reliable.
Wait, I have to wrap my head around this. If the new smile muscle in your cheek is now literally hardwired into the nerve that clenches your jaw, does that mean to show joy, to smile at a friend, you have to actively bite down? Doesn't that look or feel completely unnatural?
Initially, yes, bite to smile. If the patient wants to smile for a photograph, they must consciously, intentionally clench their jaw. But what's fascinating here is we witness the staggering phenomenon of cortical plasticity.
The brain's ability to completely rewire its own circuitry.
Exactly. The human brain is infinitely adaptable. The patient undergoes intense neuromuscular retraining and biofeedback therapy. Over time, as they practice in front of a mirror, the brain realizes that firing the jaw nerve is now creating a desired social expression. It begins to rewrite its own internal maps. Eventually, what starts as a deliberate mechanical clench morphs. The brain adapts to the new hardware, eventually allowing some spontaneous, emotionally triggered, smiling activity without the patient ever consciously thinking about chewing.
The brain literally updates its own software to match the surgical hardware. That is unbelievable.
Really is a marvel.
We've covered structural failure, gravity implants, microscopic blood vessel splicing, and brain rewiring. To bring this incredibly dense surgical deep dive home, what is the ultimate reality of these procedures for the patient?
The ultimate reality is sobering, but deeply rooted in human dignity. Facial reanimation is an absolute pinnacle of multidisciplinary surgical skill, but completely normal, flawless appearance is rarely, if ever, achieved, and that isn't considered a failure. The objective of these massive, complex procedures is not cosmetic perfection. The goal is to restore critical biological function to keep the patient from going blind, keep them from suffocating, and most importantly, to restore their humanity by giving them back the mechanical ability to express emotion and connect with the world around them.
It is about getting the biological machinery functioning well enough that the human being trapped inside can be seen again. You know, if you are listening to this right now, the sheer privilege of having an intact, functioning facial nerve is immense. The invisible machinery working flawlessly behind every laugh, every frown, and every blank you will experience today is an absolute marvel of engineering that we completely take for granted until the signal drops. And I want to leave you with a final thought, building on that mind-bending reality of cortical plasticity. If the human brain is powerful enough to literally remap the raw mechanical impulse of chewing a piece of food into the profound emotional expression of a spontaneous smile, what other incredible neurological adaptations is your brain capable of right now that you haven't even tested yet? Think about it.